Hello and welcome to the Partners in Health webinar. Today we are talking about a COVID-19 primer and how to stop its spread. I am very excited to be here with two of my colleagues, Dr. Megan Murray and Dr. John Welch. Thank you for joining us, Megan and John. It's a pleasure to have you. And I think a little housekeeping before we jump into the webinar is important. So I'm sure many people are now accustomed to Zoom meetings, but just for a little intro, if you go up to the top of your screen, you'll see view options. And we noticed that it's best to have more of a side-by-side mode set. So you can look at that and change that. And then also if you're having trouble seeing any of the slides here, you can go to the far right of the PowerPoint and you'll see a bar highlight. And you can move it back and forth to increase the size of the presentation or decreasing. So feel free to do that throughout the presentation. And just a note too, for whoever is interested, you can access a copy or a recording of this video afterwards. So if there's anyone that you know, you can always share this recording later with that particular person once we have it all set and uploaded to the website. So we'll share that as well. So without further ado, I want to introduce my friends here and colleagues. First, we have Dr. Megan Murray. And Megan is PIH's Director of Research, an epidemiologist and infectious disease expert. She's also a professor of global health and social medicine at Harvard Medical School, as well as a professor of epidemiology at the Harvard School of Public Health. So welcome, Megan, and she will be sharing slides first with us today. And then we also have Dr. John Welch. And Dr. John Welch is PIH's Director of Partnerships and Operations for Massachusetts COVID Response and Boston Children's Hospital's Senior Nurse Anesthetist and Pediatric Nurse Pediatric Nurse Anesthesia Fellowship Director. So welcome to both of you. I know this is going to be a great conversation. We already have many wonderful questions submitted. We will have a short presentation by each person here, and then afterwards there will be a Q&A session. So we will weave in some of the pre-submitted questions as well as take your questions live. So you'll see at the bottom of your screen there's a Q&A option, so you can submit your question there and chat amongst yourselves as well. So without further ado, Megan, I turn over the microphone to you. Thank you.
Great, thank you. So I'm going to talk a little bit today about how the kinds of research we've been doing at some of our sites that PIH is working on around the world, specifically around how we've addressed the spread of COVID-19. So, you know, we're really, we know pretty much what our caseload here is in Massachusetts and in the US, but it's much less clear what's going on in the many other countries that we work in. So when we started to think about what kinds of research we really wanted to do when this first happened, we came up with the following questions. We wanted to estimate the time course and expected number of cases that we would see in the various countries we work in order to predict the kinds of tools we would need to deal with it. So those tools, you know, as we've now come to realize, are things like swabs, tests, very specifically the need for hospital beds and ICU beds. That's been an issue here in the US, but you can imagine how much more of an issue it is in places where really ICU beds are in very short supply, if they exist at all. We wanted to identify people who might need special protection. So people who are at higher risk than other people. We know a little bit about what those groups are here in the US and in Europe, but we really didn't and still don't have much of an idea in the other countries we work in. And all of this is really to develop a locally responsive measures to reduce disease, death, and disability. So that's true across the board in this country and in all the other countries we work in. Next slide, please. To kind of explain how this works, I want to do a quick professor role here, where I get to explain the basic principles of transmission dynamics. By transmission dynamics, what we mean is the change in the numbers over time. So what do we expect? How do we expect an epidemic to roll out? How many people will affect? When will it go away? And much of that for infectious disease modelers and epidemiologists is guided by something called the basic reproductive number. It's probably a number you've been seeing in the newspapers a little bit. It's often explained inaccurately, but basically it refers to the number of people that would be infected by a single infectious person in a completely susceptible population with a particular disease. So in this case, what we're interested in, obviously, is how many people a COVID-19 patient would infect if they were introduced to an initially susceptible population. So that's kind of a hypothetical, because as soon as disease starts to spread, then at least some of the population is no longer susceptible because they're either infected or have been infected in the past. But it's a very useful term in terms of kind of separating out which infectious diseases are most infectious. And on one extreme, you'll see something like measles. Measles, if it was left unchecked without vaccine and without measures to reduce transmission, would probably infect 13 or 14 people, a single infectious person. But on the other extreme, we see things like the first SARS case, which was closer to 2. Sometimes the flu varies each year depending on what flu strain we're talking about, but some flu strains are not that infectious. They might infect 1.5 people. For COVID-19, we've looked across multiple countries, and the average is somewhere between 2.5 and 3. So on average, at the beginning of the epidemic, about 3 people would have been infected by a single infectious person. But what's important to know about this is that there's only really a few things that go into this number. 3, in fact. So one of those is the transmission probability, which means the probability that one will get infected if one's been exposed to the infection. So if you meet somebody, touch them, talk to them, have a close contact, and they're infected, how likely is it that you're going to become infected? And that's a probability between 0 and 1, and that can be ascertained through epidemiologic studies. The second is the contact rate. So while the transmission probability is kind of specific for different infections, the contact rate is really a function of how we live and where we live. So if you live in a rural area that's really remote, you might not make that many contacts with other people. Whereas if you live in New York City and you ride the metro, you might come into contact with hundreds, if not thousands, of people on any particular day. And finally, the duration of infectiousness. So how many days are people infectious with a particular infectious disease? The longer that we're infectious, the more people we infect. So next slide, please. So we use those numbers, those what we're calling parameters, because they are specific to a particular infectious disease, a particular place that we're interested in, to model infectious disease transmission. And that's how we come up with all those projections you've been seeing in the newspaper, saying what's going to happen, how many people are going to be infected, how many people might die over time. Those are based on mathematical models that are really, in principle, quite simple, but they get complex when we start adding lots of bells and whistles. But basically, they look like something like this. You have a bunch of people in a population. In this particular population, I've represented people who are susceptible, so don't have immunity, but as blue dots. And we're putting this one single infectious person into this population and seeing how that disease spreads. So next slide, please. So if I think the R0, the basic reproductive number, is 3, which is what we're kind of assuming for COVID-19, then that first infectious person will infect 3 other people over the course of their the number of days in which they're infectious. Next slide. And after a certain number of days, that first person is going to recover. They turn purple when they recover in this model. And the reason they recover is because they've mounted an immune response that has quelled their own infection, but it also makes them not infectious to other people. So that's good for that person. But then those 3 people who were infected by the first person, can now go on and infect 3 other people. In this case, two of them only infect two other people and one infects three people. And that's just to represent the fact that it's never the case that, every single person is going to infect three more people. Some will infect no one, but some will infect a larger number than three. But on average, for a disease that has an R0 of three more people will be infected at the beginning here. Next slide, please. So we can take that kind of a spatial structured model and put it into something called a compartmental model, which is driven by a series of equations that specify how quickly people progress from the susceptible compartment to the infectious compartment and then into the recovered compartment. So what we're assuming here is that everybody in the population can be classified into one of these boxes, that they're either susceptible, meaning they've never been infected with COVID-19, they are actively infectious now, that they have the disease, or that they have had the disease in the past and have now developed immunity to it so that they can no longer be infected. Now that's a question with COVID-19. Are people who recovered really immune? We can talk about that later, but what we believe at the moment is that people are at least immune immediately after they've been infected. We don't know how long that immunity will last. But the rate at which people go from being susceptible to infectious is a function of how many susceptibles there are in the population, how many infectious people there are. The more infectious people there are, the more likely you are to meet one of them and become infected. And then that contact rate that we talked about a minute ago. And then, of course, the transmissibility that reflects just how infectious a particular organism is. The rate at which people get better is really just given by the recovery rate, but that is the reciprocal of the number of days in which you're infectious. So if people are infectious, which we think is true now, for about almost 2 weeks, then it takes really 2 weeks for them to recover, and that gives us the recovery rate. Next slide, please. So if you stick all those numbers into a computer model that basically does some math for you and says, okay, at each time point, I'm going to figure out how many infectious people there are, and I'm going to estimate how many infectious people there will be in the next day, and see what happens over time. You get an epidemic curve like this. And this isn't particular for COVID. This is just an example. It's what we call a toy model. So I make up an infectious disease, I give it some parameters, and I stick these into a computer model, and this is what comes out. But it's typical of most infectious diseases, although this one happens pretty quickly because that's the way I modeled it. So I start out with a population of 1,000 people, it's in blue, and very quickly in this particular case, people infect each other. By 8 or 9 days, I'm thinking that really almost the entire population has been infected. This would be a model that would be closer to the measles model, where really we're infecting a lot of people with each person. And then that epidemic peaks. In this case, it peaks at about day 6 and slowly declines. And the number of people who are immune rises. Really, it's just the opposite of the susceptibles. So why does the epidemic peak? Well, in this case, it's because the number of susceptibles ran out. We didn't really have any more susceptibles to be infected. And that doesn't mean that that everybody in the population has to be infected. What it means is that I need a certain number of susceptibles around so that when an infectious person makes contact with other people, that they're still meeting some people who are susceptible and not just meeting people who've previously been infected. In this particular model, that doesn't happen until most people are infected. But if I have a less infectious organism, it will happen sooner, and I don't have to infect the entire population. And that's what we mean when we talk about herd immunity. And so when you'll hear a lot of people talking about how much herd immunity do we need to stop further spread of this disease, that depends on that basic reproductive number. And a very easy kind of rule of thumb is that the reciprocal of the basic reproductive number, so if you take 1 minus the reciprocal, that's the proportion of people that you need to be susceptible or to be immune in order to reach herd immunity. Next slide, please. So when we look at what happened in China, and when we look at what's happening, hopefully, in the US and in Europe, we've seen that the disease may have peaked already and start to decline. But in this case, it's not because we've reached herd immunity. We haven't. That would take more like 50 or 60, even 70% of the population to have been infected. In our case, we think it's much less than that. But what we're seeing, the reason we're seeing the peak is because we've put into place non-pharmaceutical interventions that decrease the amount of transmission that takes place. And those have been effective in reducing that reproductive number. So when people talk about the basic reproductive number, they mean what happens at the very beginning of the epidemic. But we also talk about the effective reproductive number, and that's just the number of people who are infected on any particular day during the epidemic. So if we can do things like isolate people when they're infectious, quarantine people who have been in contact with infectious people, or just do social distancing across the whole population, those are all ways to reduce the number of the effective reproductive number. So how does that work? If you isolate people who are infectious, you're really reducing the number of days that they could be spreading the disease. So it works by reducing that basic reproductive number or the reproductive number. If you quarantine people, you get the same effect. By quarantine, I mean finding contacts of infectious people. If you don't know whether those contacts are infectious yet or not, you keep them isolated until you find out whether they're infectious, and then you isolate them if they are infectious. And if we have the kinds of social distancing measures that we have in place right now, we just lower the contact rate. I mean, normally we might make 20 contacts a day if we're not riding the metro in New York. But most of us now are at home making only 2 or 3 or 4 contacts per day, and with the same people. So really reducing the number of contacts is having a profound effect on the reproductive number, and that's why we're seeing this peak in hopefully decline. Next slide, please. So how effective are those measures? This is a kind of a difficult slide, but let me walk you through it. If you look at the top, you see something called the latent period, and that's talking about in an individual who's infected, they go for some number of days before they become infectious, right? And then after maybe differs for different diseases, let's say 5 days in this case, they become infectious. But depending on the disease, they may or may not have developed symptoms. There's an infectious period that we just talked about. That's the number of days during which they infect others. If you look at A, where it says symptom monitoring and quarantine, in that, and you look across that infection event column, row, we see that the symptom onset for disease A begins prior to the infectious period. So this is a hypothetical infection in which you get symptoms before you become infectious. And there are some diseases like that, smallpox, for example. In that case, quarantine and isolation are going to be really effective because we're going to know pretty much everybody who's sick, everybody who's infectious. They're going to be obvious because they're going to show up with an illness. In the case of smallpox, it's going to be a rash. It's pretty unmistakable. You can isolate that person, and as long as that person's completely isolated, there's really no one more that they can infect. For disease B, the onset of symptoms happens at the same time that the symptoms happen. So symptoms happen and infectiousness happen at the same time. And in that case, if you can get people quickly enough, you still can have a pretty good effect. But in disease C, the symptoms start after the infectious period starts. So people are walking around infectious. They're not sick yet, and so they don't know that they're infectious. And they can be spreading disease without having any idea that they're sick. And that makes things much harder, right? Because you can't, since we don't know who they are, we can't isolate them or quarantine them. And then we're stuck with things like social distancing. So next slide, please. So this again is another somewhat difficult slide, but I'll walk you through this one as well. So on the x-axis, on the horizontal axis, we're looking at the proportion of infections that happen prior to symptoms or by asymptomatic infection. So we know with COVID-19 that some people never develop symptoms and they are still infectious. So there's really no way we can find them at all. So if nobody is infectious prior to developing symptoms, like with smallpox or SARS, and that's on the far left, you see these diseases that are fairly easily controlled. If you isolate all the symptomatic patients, you see complete control of SARS and smallpox, SARS-1, not SARS-2. If you isolate 90% of people, that's B, panel B, you still get pretty good control. But if you're only isolating 75%, even with these easy to manage diseases, you may still not see good control. On the other hand, at the far extreme is HIV. So HIV is probably infectious for many years before people actually recognize that they have symptoms, if they're not being routinely tested. And in that case, it's pretty difficult to control HIV through these kinds of non-pharmaceutical methods in any case, because unless you're going to go out and test people and find them early in their course. So measures like just isolation of cases will not be effective. Influenza shows up in the middle of that, and unfortunately COVID-19, which slide was created before COVID-19 happens, shows up a little bit to the right of influenza because it's has a bit of a longer infectious period prior to symptoms occurring than influenza does. So next slide, please. So that slide I just showed you is asking what would it take to really get the disease under control, and by under control they mean flattening out completely so that there's no further rise in cases, and it just stays at the same level. But what we mean when we say flattening the curve, which is a term we're hearing a lot these days, is that even if we can't change the infectiousness of the organism, or eventually we'll have to go back to some social mixing, we can slow the pandemic, and this pandemic in particular, by putting into place measures that we hope are fairly temporary that involve social distancing. And what we mean, what's the purpose of slowing? So I get a lot of questions about this, and people say, well, aren't we going to end up with the same number of cases anyway? Well, for one thing, we probably won't, because as I showed you before, that basic reproductive number, the number of social contacts we make is part of that. If we go back to completely normal activities like we were doing before, we may end up with the same number. But the purpose of flattening the curve is to delay the peak and spread it out so that the capacity of the healthcare system is not overwhelmed. If you have, that line you see in the middle there is the capacity of healthcare, meaning, for example, the number of ICU beds, the numbers of nurses and doctors, the amount of available treatments, say ventilators. If you max that out and you exceed it, then those people are going to have really bad outcomes. And furthermore, they're going to be more infectious because they're not going to be properly isolated. If you can keep the number, even at its peak, as in the purple, below that maximal healthcare capacity, then you're really going to be able to continue to provide reasonable medical care during the whole epidemic, even if it goes on for longer than it would otherwise. So next slide, please. So the work that we're doing in the countries we work in with Partners in Health has two main foci. We want to know where are the hotspots, where is a lot of transmission happening, especially in the countries we work in where testing is not available at all, and we don't know what proportion of the population is infected, or if we're about to hit a place where ICU beds are going to be desperately needed. But we also want to know how much immunity we've built up in the population, because this will give us a sense of when some of these measures can be relaxed. If we knew that 60, 70% of the population had already been infected and were immune, then we could really expect that this social distancing we're experiencing now could be shortened. But if we thought that only 5%, 2% of the population had been infected and were immune, we know that there was going to be a lot of time that we would still have to be finding measures to control the spread. So one of the ways we've been doing that work in places where there's not good testing, so a lot of the countries in Africa that we work in and in Haiti, is to go back to public records on the numbers of flu-like syndromes that were being reported by different healthcare facilities. In some cases, those are our own hospitals. In some cases, they're government reports, to see if there was any indication of an increase in flu-like syndromes back in January, February, and March that might have been attributed to flu, but really were due to COVID-19. And in some cases, we have found some evidence that there was a signal of increased flu or flu-like syndromes back as early as February. We're trying to now go back to those areas and do seroprevalence testing now that we have increasingly available tools to see if those syndromic infections were actually due to COVID-19. But we also want to do serosurveillance, meaning we go out and draw blood, measure how much infection is taking place across the board, and particularly in this case, to figure out whether people who have been infected are no longer at risk for disease, because those are the people who can rejoin normal world and interactions if they are immune. If they're healthcare workers, that means that we know that they can be put on the front lines without major risk. Now, I should make the caveat there that we still don't know from a long-term perspective how long-lasting immunity might be, if it's complete, if infections can return. So it's not a given that if one has tested positive in the past and now has antibodies, that one is now free from infection. But we have reasonable expectation that there will be some, at least short-term immunity. Next slide, please. Another really important focus of our work is to look for risk factors for severe disease so that we know whether we're going to see really high rates of disease in some of the populations we work in. We know from work in China and Italy and the US that age is a very strong indicator of risk. We also know that having cardiovascular disease, hypertension, diabetes puts people at risk for severe disease and death. But what we don't know yet is whether diseases that are more prevalent in lower income areas, in Africa, in South America, in the Caribbean and Asia, are also risk factors for severe disease. There's not enough data yet on whether HIV is going to alter the course of COVID-19, whether malnutrition or just poor nutrition, even if it's not low body mass index, is going to affect the rates of disease in places like Africa. And so we can't really yet know which populations we need to provide protection for. So as part of our research, we are trying to identify risk factors in the countries that we work in and follow the people with those risk factors to see if they're going to become infected and if they're going to get disease. Next slide, please. The good news from some of those countries is that because the strongest risk factor, at least in the US and Europe and China, has been age, the fact that the age distribution in poorer countries is really shifted towards younger people may be a good thing. Now, it's not really a good thing in the long term, because the reason that the age distribution looks the way it does is because there's so much disease and risk factors for disease in those countries that people don't live as long as they do in wealthier countries. And so the proportion of the population that's over 60 is often really quite low, 5% across Africa compared to, say, 25% in the USA and Europe. 51% of Africans across the board are under 20 years of age, compared to 25% in the US and 23% in China. So if children are protected, that's a good thing. And it may mean that there's the indirect effect that if children aren't infectious and carrying disease, even if they're not sick, that might protect older people as well. Next slide, please. But we also know, as I mentioned, that comorbidities like cardiovascular disease, this is a table from the Lancet. The important column is the one that says multivariable odds ratio, or OR. And really, that study suggests that the strongest risk factor, other than age, was having heart disease. So we know that the rates of heart disease, while they exist across the world, are lower in some parts of Africa than they are in the US. So that, in addition, might be a good thing for these countries that really have no capacity to fight back against this disease. Next slide. These are a map of cardiovascular disease risk throughout the world, and what you see is that Russia and China or Russia mostly in the Eastern Europe, has very high rates of death due to cardiovascular disease, and that those rates go down precipitously in other countries. Next, please. Here's some data on HIV. There really is remarkably little published so far, but what this study from 2 districts in Wuhan that followed AIDS patients mixing in the population suggested was that HIV put people at no higher risk than other people. In this particular case, all of the patients were well treated and had viral control, so they were getting drugs. They were taking these drugs. Interestingly, I just read a report yesterday that one of the things that's happened since lockdown happened in China is that many of these patients have gone off their drugs because they can't access them. So we might be seeing something different as time goes by. But at the moment, it's not clear what effect HIV will have. Next slide, please. We also think, although there's some controversial data out there, that smoking probably increases the risk of most respiratory infections and probably COVID-19. And while it's true that the proportion of the population that smokes is low in poorer countries, largely because people can't afford tobacco, it's also the case that people use what we call biomass fuels, so either wood, dung, dried dung, or other collectible items to cook and to heat their homes with. And that causes indoor air pollution, which really has pretty much the same effect as smoking. So while it looks like Africa is relatively free of smoke-related disease, that actually is not the case. Africa has very high rates of deaths from respiratory infections, and it's thought to be in part due to this exposure to indoor air pollution. Next, please. We also know, of course, that stunting, which is food deprivation early in life that leads to long-term disability, is most common in Africa and in parts of the subcontinent of India and Pakistan, Bangladesh. And as so far, we really have no idea what impact malnutrition and stunting will have on COVID risk. Next. We know that some micronutrients are strongly associated with respiratory infections and viral diseases. And particularly vitamin A deficiency has been linked to multiple infectious agents. And one of the things you're seeing here again is that Africa, India, parts of Latin America really have persistent vitamin A deficiency, whereas wealthier countries, which have better nutrition, vitamin A levels are normal. Next, please. But of all those risk factors where we're not quite sure how they sort out, one thing we really do know is that capacity in poor countries is really very much lower than it is in the countries that have seen these huge rises in COVID-19 so far. Next, please. Here's a study that I did with some colleagues where we mapped the Wuhan epidemic onto what might happen in the US. So on your left, you see the number of seriously ill patients over time and the number of beds that were present in that area. And then if you look at the right, we said, what would happen if we saw the same kind of epidemic, and this was before we actually knew what the epidemic was going to do in the US. And what you see here is that although we did have enough ICU beds to accommodate most of the cases, even in the worst case scenario, those aren't empty beds. There's a lot of people in intensive care units now who require those beds. And so if you look at empty ICU beds, we're going to really exceed our capacity. And that's pretty much what we've seen. So next slide. But I did a study with a group that had really assayed the amount of ICU capacity in Malawi. This is led by Paul Sonnenthal and Shada, who works in Malawi with PIH. And really what you see here is that there's so few ICU beds in Malawi and ventilators in urban Malawi that a Wuhan-like epidemic would very quickly overwhelm the system. And that is even more extreme in many other countries in Africa. I understand that there's only, I think, something like 10 ventilators in all of Sudan. So you can understand that if we saw even a much less vigorous epidemic in these countries, capacity would be very rapidly overwhelmed. Next. So just to summarize, our goals are to use syndromic surveillance data, either national or from our own hospitals and our own sites, to try to detect hotspots that might not have been detected so far because we don't have testing capacity, to do serosurveillance, so prevalence studies using antibody tests to understand where we are in terms of developing herd immunity across the many places we work. We're trying to identify specific risk factors for severe disease that are unique to the low and middle income countries we work in, so that we can assess needs and capacity and identify which populations need to be most protected. And then we've tried to assess capacity, and we found that overwhelmingly it's we're way under our current needs, even for disease without COVID-19, but especially in the context of this epidemic. And then we've worked to model trajectories in different countries so that we can plan for how to respond adequately. So thank you, everybody. I am really happy to answer questions. I know John's going to go next, and then I'll be available for other questions.
Thanks so much, Dr. Murray. And I always learn so much by listening to you, to listen to you speak, and reading all of the things that you write. So thanks for that very in-depth look at some of the epidemiologic perspective for COVID. So it's great to be with you. Thanks for taking your time. I know people have interesting and varied schedules these days, so thanks for taking a bit of time out of your afternoon with us. I'm gonna just talk to you a little bit about the contact tracing efforts here in Massachusetts, and try and tie those back to what Dr. Murray was talking about a little bit. Contact tracing is an important piece of the public health response to any epidemic, and really endeavors to break the chains of transmission of any infectious disease, but in this case, COVID. Partners in Health has worked for decades now around the world doing contact tracing for a variety of different diseases. Tuberculosis and HIV in Haiti. We've responded to cholera outbreaks there in Haiti as well, to our West African Ebola response and onward. So, what I find the most interesting is all of our work that we've done and we've learned from around the world. We're now bringing that work and those lessons back to the United States to really implement here. And I think it's fascinating, and it's really heartening, I think, for us to be able to do that. Particularly because there's often this idea in global health that we're the great thinkers, and we have all of these tools and all of these ideas to export to the global south. But really in this situation, all of the lessons that we've learned from countries and communities that use these techniques day in and day out are really applicable here. So what does that look like in Massachusetts? That is the Community Tracing Collaborative. The way that works is that a person who's tested for COVID, that result comes through the state database, and that information is shared with our collaborative. It's all kept private and secure. Once we receive that information, one of our case investigators will call that individual who's tested positive and really do a few things. The first thing is to make sure they're okay. It may have been a day or so between the time of getting tested and this phone call happening. So we want to make sure that person's still doing okay. Number two, that they understand what isolation is and how to safely isolate. Remember, Dr. Murray was talking about how important that is to affect the R naught, or that reproduction number. And so we've got to make sure people understand what that is. Number three, that they have the tools that they need to safely isolate and quarantine. You know, one of the lessons that we've learned for many years, and part of the PIH model, is accompaniment. That really means that we're making sure that not only do people know what the tools are to stay safe and to be partners in their healthcare, but actually that we're seeing to it that those tools are provided. So that's an important piece of the case investigation, is just making sure that those tools are there. And then finally, and really most importantly, in contact tracing, is gathering the line listing of everybody, of the contacts that someone's been around. Close contact right now is defined by the Massachusetts Department of Public Health and the CDC as someone you've been within 6 feet of for 15 minutes or more. Now, I think there's a lot that goes into those definitions, and certainly other countries have used much stricter definitions. And I think if we went back a few slides, we don't have to, but if we did, we could understand how that fits into the equation of what R naught, or the reproduction number, is. And so just trying to tie our two conversations together here. So that's sort of the definition. And we're looking for people who have had, for what that contact has been, for 48 hours prior to symptom onset. And again, using this definition specifically for COVID, because that was sort of the ABC disease scenario, and we're talking about that C scenario, which is that there can be transmission prior to symptom onset. And so that's why we're using these definitions. And those phone calls can take a bit of time. We're fortunate in this moment in the epidemic that those efforts for social distancing and the stay-at-home orders have really reduced the number of contacts per case. We're seeing a mean number of contacts per case in Massachusetts for the cases that we're managing to be closer to 2 or 3 right now, versus early in the epidemic, it could have been up to 10, sometimes even more. So those measures are effective right now. What we see is those stay-at-home orders are loosened, and there's more socialization that's happening, is that we expect for that number of contacts per case could rise. And that's something for us to keep in mind. Once we've collected those, I'm sorry for the background noise, I'm very close to the hospital. Once we've collected those contact listings, then we share those with our contact tracers. The contact tracers then reach out to each one of those individuals and also do a number of things. First thing that they do is make sure that person's okay. They are now a known contact of a person who's tested positive for COVID, and it's a potential that they become sick. So we want to make sure if they are sick, they know what to do, where to go, that we can provide them the information that they need. Second, we want them to understand what quarantine is, and to make sure that they have the tools that they need to safely quarantine. And then finally, that they know where to go for a test and when to go for a test. And it's really important that these activities, this contact tracing and testing, are pretty closely tied together. And it's also really important, because of all of the information we just learned from Dr. Murray, that a single test, particularly in a virus like COVID, can't be seen as the panacea that you never will have COVID and you don't have COVID. It's very important throughout that quarantine period to understand when the most reasonable time for testing is, and especially if someone becomes symptomatic. But really with COVID, this is why contact tracing early is, reaching those contacts early is so important, to make sure that those people are quarantining and not potentially spreading the virus if they're during the potential for asymptomatic transmission. And then we're reaching out to all of those individuals, both cases and contacts, throughout the course of their illness or their quarantine. So we're checking in on them on a regular basis, making sure that they understand that we're continuing to follow them, that we're here, answering their ongoing questions about isolation or quarantine, and then finally reassessing those social needs. And so we have a really important piece of this community tracing collaborative, and that is our care resource coordinators. So you can see in the bottom kind of left hand portion of the slide here. Those individuals are responsible for connecting people to the resources that exist in their community, to make sure that we are providing for those social needs, the basic human rights of people who we're asking now to stay isolated or in quarantine. And certainly our lessons from around the world have shown us that important. But one of the lessons I learned working during the Ebola epidemic is that quarantine and isolation using force and fear is really ineffective. And people will leave that quarantine and will even leave isolation and treatment if you're not giving them dignified care, if you're not providing for those basic human rights. And so this is things like food delivery. This is prescription delivery. Dr. Murray alluded to looking at some of those HIV patients and the curiosity and really the negligence of providing those folks with their antiretroviral medications. And we know how dangerous that can be to come on and off of those medications. So, it's essential if we want things like quarantine and isolation to work and contact tracing to work, that it's all very well integrated into a system that is really socially just and is founded on this idea of accompaniment. So we're doing this here in Massachusetts now. We have reached over 35,000 cases and contacts. We make anywhere from 8,000 to 10,000 phone calls per day. We've employed around 1,700 people. Those aren't all full-time individuals, and those are some of our partners with our community health centers, which has been a fantastic partnership, as well as some donated time actually from Blue Cross Blue Shield of Massachusetts has given us a big donation of human resources, which is just really sensational. And I'll also just end by saying that contact tracing is not something that we invented. This is not a Partners in Health invention, and has been happening here in Massachusetts and around the world at the local level. Our chief medical officer, Joya Mukherjee, always says that all epidemics are local. And that's true here in Massachusetts as well. The local boards of health are really the experts in contact tracing. And this community tracing collaborative is an effort to really provide them additional resources and additional help as the cases fluctuate. And they also focus on keeping our community safe through the reopening, et cetera. We can provide this as a service to them. So I'll just put that out there. And I'll stop now so we can take some questions. Thanks, everybody.
Thank you, Megan and John. This is Leslie Friday again from the Marketing Communications team with PIH. And this has just been a fantastic presentation. I really thank both of you. And I want to jump into the questions. We have many of them. I know we won't be able to get to all of them, but let's try for a good 10 minutes to address some of them at least. And what I've seen at least come through are a number of questions about antibody tests and their importance in this entire response. Maybe Megan, if you could talk to that a little bit, the availability of them and the importance of them in this response, please.
Yeah, so it's actually a bit tricky. So antibody tests measure whether you have developed antibodies to the organism. And that doesn't happen until about a week into infection, sometimes a little bit longer. So it's a good indication that one has been infected. There is some overlap with when one first becomes antibody positive. There's a few days there where one could still be infectious or still have disease. But then one remains antibody positive for, we don't know quite how long because we haven't had time to observe this, but we know that that people who were infected back in January, February are still positive now. So the antibody test is not, in this country, is not used for diagnosis of disease. We use a viral load test to see if people actually have virus in their bodies. But it's used on a research basis to see how much immunity there is in the population. And ideally, you know, in the future, if we understood this a little bit better, it might be a way to tell people, yes, you're not at risk for getting infected in the future. I don't think we're quite there yet because we don't know exactly if people with antibodies are completely protected. But it may be that at some point individuals would know their antibody status, like we do, say, when you get a vaccine for measles and you go off to college, you have to show that you have antibodies for measles, that you've got them from the vaccine in order to be allowed to go to, you know, these group functions. So it's a very useful tool. It's a particularly useful tool for epidemiologists to kind of get a sense of, are we anywhere near herd immunity? But it's not really a clinical tool for saying, are you sick right now? If you feel sick and you go in, you're not going to get an antibody test. You're going to get a viral load test.
Great, thank you very much. And this one for John this time. There's a question, I think, about you know, robocalls in the process with contact tracers. You know, many people are accustomed to screening their calls. And, you know, how is this impacting contact tracing in Massachusetts? Is that affecting our response in any way?
Yeah, great question. And you know, our campaign has been to, you know, to answer the call, and that sort of this, it's an act of caring for your community to answer the call because having this information is so important. Certainly, we have become one of those entities that is trying to reach out to folks. And we've gone to great lengths to make sure people understand who we are and why we're calling. The first was to generate a unique caller ID. And so if we're calling folks here in Massachusetts, you'll see the MA COVID team come up on your caller ID. It turns out it's actually much more complicated to get one of those caller IDs in place and have that pushed out to individuals than we thought. But we've had great cooperation from the downstream telecom companies to make sure that happens. And so those of you who have been paying for caller ID, I think for the next 4 months, it will be free. So you're welcome. And then we leave voicemails so people understand, you know, what we're calling for. We don't leave any personal or private information on there. We just simply say, we've got some information for you about COVID and we'd like to speak with you. And then we also send out text messages as well, just so people understand really what it is that we're calling for. I'll also say that we'll never ask for any health insurance information. We'll never ask for social security numbers. Really, the most important thing is sort of name and phone number. So I'll put that out there as a PSA. But we kind of have a series of calls that we make. We call people a couple of times in a short period of time and then call them back at a different time later in the day. and then we keep on them for a couple of days before we try and reach out then through the local Board of Health, whether by mail or on foot or by delivering a flyer or something, because it really is, to break these chains of transmission, it is really so important to be in touch and to inform contacts.
Wonderful. And unfortunately, I think we have time for one more question, and I'm going to direct this to Megan, actually. There's a question about how do you identify someone who is asymptomatic or pre-symptomatic, who could be a silent spreader, so to speak. Is that even possible? Are there tests for these types of things?
Yeah, I mean, if you have a suspicion that a person might be, or you have been infected, even though you have no symptoms, and you get tested with a viral load test, we think that the viral load corresponds more or less to infectiousness. So if you just went out into the population and say took all healthcare workers and tested them for viral load, some of them would be positive without having any symptoms, and that would be a way to test for them. But it's not really possible to test everybody, and we'd love to do that, but we probably can't. And furthermore, we'd have to test them frequently, not just once. So the best way of knowing whether one might be either pre-symptomatic or asymptomatic is to do this kind of contact tracing, to know if one's been in contact with a person who eventually developed infectious disease. Now, it's possible that one was exposed to someone who was asymptomatic the whole time, and then that the next person becomes asymptomatic as well, but still could transmit. So this is really the challenge of COVID-19, why it's so much harder to control than SARS-1 was, or other flu syndromes have been. And it's not an easy thing to solve.
Thank you very much, Megan and John. And I feel like we could probably occupy an entire hour of just questions from folks. So thank you to both of you, a really informative presentation. Thanks for all of your questions and interests. I know we're getting very positive feedback on this, that people have really enjoyed this presentation. So thanks to all of our attendees, also who are listening. And if you do support PIH, thank you as well. We definitely appreciate your contributions to this very important work here and all over the world. And I will say, just as one last bit, this will be in its entirety posted on pih.org on our webpage, so you can share it if anyone did miss this presentation, as well as the slides will be shared. And please also visit us on our social media channels. You'll find us on Facebook, Twitter, Instagram, and LinkedIn. And definitely visit pih.org for more information. Again, thanks, Megan. Thanks, John. And thanks to everyone for listening today.